Hello, this is Sarah Jane Mee. Let me introduce you to Melissa, who's a paramedic.
It's no news to anyone that the NHS is a bit stretched at the moment, and obviously that's going to have a knock-on to all sectors, and the ambulance service is definitely feeling it. But in my area, we haven't been queuing with people in the back of ambulances outside of hospital for a long time, and that's a huge step forward. But they're still being left in corridors. When you do take them into A&E, they're having to wait hours and hours in the corridor half the time, just because there's no space, there's no beds available yet.
On the next few episodes of the Sky News Daily, as winter puts all its usual pressures on the National Health Service, we wanted to do our own checkup on the NHS, starting in accident and emergency, the area Melissa works in. I'm alongside someone who really knows the NHS. In fact, he used to run it.
Patricia Hewitt, one of the Secretary of States I worked for, said that if the NHS was a country, it'd have been the 33rd largest country in the world. So it's a massive enterprise, but enormously important for the heart of the country.
That's Sir David Nicholson, who was in charge in England. He'll help us navigate the issues and talk about solutions for some of the bits of the health service we're most familiar with. Before David and our guest, more from the Frontline and Melissa.
I've been a paramedic in the southeast of the UK for 3 years now. Thankfully, for the most part, I still love the job. It is 5:30 on a Saturday morning. It's raining quite heavily, which is adding insult to injury. And I'm off for my 5th shift of the week. Hopefully 10 hours. I say hopefully because we've overrun twice already this week. So that rather abrasive sound was the call we get when a job's coming through. So this means we're off to another call, another emergency. And this one is a very confused male who can't be properly woken up by his wife. He's not making sense. This could potentially be a very unwell chap. We'll head over and see him now. Even though we see these sorts of situations all the time, for a lot of people, you're turning up in their worst hour, really. Some of their scariest moments, almost upsetting moments. If you can alleviate some of that stress, not just with like the knowledge and skills, the things that we do, but just being a presence there to kind of calm the situation, I guess. I find that incredibly rewarding. That's probably one of my favourite aspects. So an update from that last chap. We're querying sepsis. Quite a big chap. Lots of furniture in the way of the route that we wanted to take with our stretcher. So we had to do like a quick furniture rearrangement for his poor wife. We used the fire service quite a lot for tricky extrications. But thankfully we managed to get him out quite swiftly under our own steam this time. It's probably no surprise to anyone that we're a bit stretched, but it's the reasons why we're stretched which get frustrating. Namely, consistently being sent to things that just aren't emergencies. 111. It's a great system when it works. People will often call for just advice, whether they say something over the phone that sounds worse than it is, or if they just tick certain criteria that will naturally trigger an ambulance. That's happening a lot. There's lots of good things being done. For example, we have a hospital at home team, and it's basically trying to keep the elderly out of hospital because it can be so detrimental to take the elderly into hospital. They have all sorts of skills they can do, as the name implies, keeping them at home, but with treatment they need. We're trying to share the pressure, share the load. Everyone's doing their best and just doing what we can with, a smile on our face.
We'll hear more of your stories throughout this series to help us understand the issues facing the NHS, particularly in England. Former NHS boss Sir David Nicholson is with me. Before we get into the challenges of A&E, David is going to give us a quick history lesson about its original role.
It does go back quite a way. In the 1960s, there was a thing called the hospital plan. And the idea was that for every population, there'd be about 250,000 people. There'd be a district general hospital. There had been big hospitals around for a while, and each of those would have its own casualty department or accident emergency department. I was the chief executive of a hospital in the 1980s. The A&E department, as it was then, wasn't, how can I put this in the nice way? It wasn't the sexiest place that people necessarily wanted to work. This covered a population of about 300,000, and there were two A&E doctors. One of them was an orthopaedic surgeon who didn't really want to be an orthopaedic surgeon, and the other was a hand surgeon. There were no properly trained emergency doctors at that particular moment in time. And of course, that's been completely transformed over the last 20 or 30 years.
Since then, David oversaw the Labour plan to get 98% of patients seen within 4 hours, a target which slipped to 95% by 2010.
I think what's happened with the impact of COVID, it's sort of accelerated a whole set of things that were happening in the NHS as a whole. So the pressure on A&E departments has become absolutely enormous. And we saw last winter, the terrible circumstances, patients being harmed, patients being left at home, ambulances, all the things that everyone will have seen on their televisions and those staff who've been working on it. Now, the question is, so what are we going to do about it? There's a short-term set of issues I'm sure we'll get into, but also I think there are some more medium and long-term issues. I think we broadly know the sorts of things that we need to do, but we've been very poor so far at implementation.
So how do you improve accident and emergency, the place that's perhaps become the most oversubscribed and overstretched?
As society changes, one thing that's stayed the same is 24-hour availability in one particular place of a healthcare team of doctors and nurses. And the population, if any other bit of the system fails, they know it is the absolute safety net in there. So as the pressure's built up, and we saw in COVID, the number of people in our population who are suffering from chronic illness and chronic disease, as you see all of that, the place that they always end up at when that part of the system doesn't work is the A&E department.
Let's bring in Dr Adrian Boyle, President of the Royal College of Emergency Medicine and consultant in emergency medicine.
Where we run into problems are the people who need to be admitted into hospital. And what we see is those patients end up with very, very long stays. Throughout the year, we were having hundreds of thousands of people each month spending more than 12 hours in an emergency department. And our emergency departments simply aren't designed for that. So we call this crowding. It's not actually because it's the only place that people can go to. It's often that it's actually just really hard to get out of.
Figures from the Royal College of Emergency Medicine found that in 2022, around 400,000 people spent 24 hours or more in emergency departments. It begs the question, why?
The number of beds we've got, we could probably get away with if our social care system was able to do all the things that we needed to do. We have almost the least number of beds per head of population of any comparable country. The only country that has less beds than us in Europe is Sweden, but they have really good social care. So people get stuck. And at any one time, somewhere between 10 and 15% of all the beds in hospital are taken up with people who actually don't need to be in hospital. So the fundamental problem is the lack of capacity in the system.
If you go back a couple of steps, actually, it also relates to primary care and also relates to 111, the telephone response system. All of those things can affect flow depending on how they operate. You've then got the A&E department itself, and as Adrian will know, there's been all sorts of innovations around same-day emergency care. But Adrian is absolutely right. We need somewhere to move these patients to get the right care that they want. I've experienced in hospitals where, you increase the number of beds by 100 and all you do is increase the length of stay of everybody. I think the distinctive characteristic of our system is the relationship with social care and how we build social care capacity in the system to enable that flow to happen.
I also don't buy that fixing social care is that hard. I think this is very much a fixable problem.
It's the whole system. In terms of the conversations about it, it's almost, lots of people believe they have a silver bullet and this is it. When actually there isn't. I don't think there is one.
There's something that's come into the thinking of the nation in recent years about stop and think if your local A&E department is the best place for you to go. David's mentioned there 111, which we keep being told, call them first, unless, of course, there is a threat to life. What's your view on the before you get to A&E actions that people can take that would help the A&E department?
People talk about, all these strategies to try and stop people going to emergency departments. as some sort of fix, and it's not. If you actually look at the numbers of people going to type 1 emergency departments, it's actually stayed very static. We're not inundated with new arrivals. What our problem is, we just can't move people on. Now, in terms of what we can do to try and improve matters before people get to hospital, well, if you've got a clinical problem, you need to be able to talk to a clinician. And if you look at NHS 111, and we all complain about NHS 111, possibly a bit unfairly, but actually it works best when the call handlers have access to a clinician, either a nurse, paramedic, or, as the most expensive but most effective option, a GP. Likewise, good access to primary care would help. If we look at international models, different international models, for instance, in Holland, you can't walk into an emergency department. You either have to be taken there by an ambulance or referred by your GP. Now, that's a massive paradigm shift in the way that actually pushes care out of hospital into the community. I don't think we've got enough GPs to do that in this country at the moment, but clearly, as a way of actually trying to stop people requiring emergency department unnecessarily, that's one way it could be done.
The other example is Denmark, of course. Do you think we should think about that here? Because I know it's been mooted. There was a campaign at one point. Do you think it's realistic?
That's a massive shift in the national psyche, isn't it?
But we've got a massive problem.
Yeah.
We don't have enough GPs to do it. I mean, the fundamental problem is that you need to have lots and lots of GPs to do it. And this is not a cost-neutral thing to do. The government needs to put money where their mouth is and say, we are going to do this. We're going to invest massively into primary care. And this is the deal. I talked to doctors from Denmark and Holland. They actually really think that it improves the care they can offer to their most seriously ill patients because that care is reserved for them.
There is a big issue here about management capacity. You won't be able to implement some of these things without really much better skilled management cadre in the system.
We've talked about, access to A&E. We've talked about what happens when you get into A&E, where you go from A&E, touched on beds, touched a little bit on social care. Where would you like to take us from here, Dr. Adrian Boyle, in terms of finding a solution to making your life, quite frankly, and your patients' lives better in A&E?
I think we need to make it easier for patients to be discharged from hospital. And I think this means that we need to create a shared mental model of shared risk right across everybody. It is incredibly disproportionate how much different clinicians are prepared to take levels of risk. Our GP colleagues hold vast amounts of risk, so do our ambulance staff. And as every stage within the hospital, as far as I can see, the level of risk people are prepared to tolerate gets smaller and smaller and smaller until they get to discharge, where it is almost impossible to get somebody out of hospital and into social care unless absolutely everything has been done. So people are held in hospital, not recovering, actually getting worse. I go into my emergency department, I'm going to be working tomorrow night. There may be 100 people waiting. All I'm going to be able to concentrate on it is on the patients in front of me. I will take some risk and I'll take judged appropriate risk. But I also, at the same time, I want my colleagues in the inpatient wards and actually the people responsible for discharging people to feel that same sort of pressure and that same sort of urgency for our patients.
Risk is a really important issue, and very often in conversations about the system, people are shifting risk. And I think what we saw more last year than I'd ever seen in my experience in the NHS was the risk being shifted to patients and families in a way that no one had kind of thought they were doing. That's what was happening to us in all of this. But there is no kind of common approach to risk across a hospital. And one of the things we didn't some years ago, but now we have brilliant evidence about how harmful it can be for older people to stay in hospital longer than they need to be. I know people have traditionally thought hospitals safe places, but for someone in their 70s or say 80s with frailty, it's deadly. It's absolutely deadly. I think there are some statistics, I'm sure Adrian will know, about what's likely to happen to you if you stay in hospital long. So it's a real patient safety issue, this thing about risk. it's not acceptable anymore to leave people to suffer in that kind of way. I think we need to think more creatively with the local authorities about how we organise social care. Now, for what it's worth, I've advocated for a long time that social care staff should be on the same terms and conditions of service as NHS staff. Now, I know there'll be a cost for that, but I think it would be more than offset by the efficiency of the system. If I can give you an example of a hospital that I've been responsible for, we advertised for healthcare assistants. We got 30 applicants, 28 of them currently work in social care. So we'd be doing the worst of all. We'd be in a situation where we'd literally be taking people away from social care. And that can't be right, because it pays better.
There have been sort of interesting experiments where hospitals have bought their own social care capacity, really to try and protect their bed base a bit better. It is a big thing. I will be, when all the election manifestos come out, I'll be scanning them and seeing, what are you saying about beds? What are you saying about social care? Because those are the fundamental problems which are limiting our ability to do good hospital care at the moment.
There are quite a few ways to fix the problem we're talking about, but it's not like nothing is being done. There are things to be optimistic about, encouraged about. David, what can you see happening in this sector around A&E that gives us encouragement that things may well get better at some point?
Some of the innovations that are happening, virtual wards, for example, using technology to keep people in their own or getting them out earlier, all of those sorts of things. These things do need to be properly evaluated. But we need to try out new things. Innovation, I think, is going to get us out of this issue, thinking differently about the way we do it. At the moment, we're kind of facing just an ever-increasing set of problems that we're trying to fix, when actually we should be thinking much more strategically about what we really want.
I think the biggest cause of optimism I have is that, certainly talking to other people around the country, there are people who are actually not lying down and taking a kicking. They're actually fixing it. Simple, basic things about improving the silos between emergency departments and GPs. So making sure that a GP can phone up a hospital and get some advice really easily and really quickly. Now, it sounds like an obvious thing, but it is certainly not routine. And it's just sorting out the basics, making sure there's a phone that the consultants know they have to carry when they're doing that piece of work, so they can provide that sort of advice. In terms of other things that made me optimistic, my experience of working during the strikes, when suddenly there was just a little bit increased capacity, there was a massive increase in the senior decision-making ability, suddenly everything flowed much better. I look at actually the shifts I did covering the junior doctor strike as actually some of the most enjoyable work I've had over the last couple of years. So this is a fixable problem, and it can be fixed quite quickly.
I'm interested in what you said there in terms of, obviously, nobody wants more strike action, but did you find that the A&E department was more streamlined?
During the strikes, a lot of elective activity got cancelled. So suddenly the hospital had more capacity. So thinking about the whole system flow, actually, there were less people coming into hospital for elective work. This meant there were more beds, but also the doctors working on those wards were more senior. So actually they were discharging people earlier, more efficiently. Certainly the strikes time, the reduced capacity, the increased senior cover on the wards, dramatically improved flow through departments.
The way we describe it in this country is we have a consultant-led service, whereas in some countries they have consultant-delivered service. And what that means is you need a lot more consultants. So to do that, you need to have that as an objective and then plan in advance and work towards it. At the moment, I think we kind of stumble a bit, and then we end up not being able to implement things that make absolute sense because we didn't make that 3 or 4 or 5 year commitment that we needed to sort of change the way we work.
Just a final thought for you, Dr Adrian Boyle. You're going back to work tomorrow, I think you said, back into A&E as a consultant in emergency medicine, back seeing your patients. What would you like people to take away from this discussion about the state of A&E and what it will look like in the future?
I really worry about the public's confidence about accessing emergency care. And I think a lot of the negative press around is actually potentially very harmful. And I worry about people who, usually elderly, the mustn't grumble generation, not seeking help when they should. And I think there is a danger with a lot of the stuff that goes on in the media and the messaging that colleges, myself and all sorts of commentators put out, that we discourage people from seeking help. So my message to the public would be absolutely seek help if you think you need it.
Across the country, people being fantastically ingenious in the way that they're coming up with solutions to these problems. So I think what we need is a compelling strategy that politicians will sign up to say this is where we want to get to, and then we can all get in behind it.
Next time, living with cancer.
My specialist nurse called me in along with my wife. She sat me down and she said, "I'm sorry to say, Graham, you've got aggressive grade cancer." And as you can imagine, that emotion immediately was, well, filled with fear.
We look at the challenges when it comes to cancer care in England and discuss how innovation is transforming the lives of patients living with the big C.